devices. Does it? Hello, Amaka. Should I go back or I should continue?
Continue.
No,
Sorry.
I'm asking her because of the recording.
Okay, just you can just go back, I think. Thank you.
Okay, so this was where the recording stopped. So I'll
Okay.
just quickly recap that.
All right,
So
thank
this
you.
laboratory-based word surveillance is a hybrid method that balances laboratory results or laboratory surveillance with word-based surveillance. It involves monitoring of positive microbiology results and then following up with ward visits for verification. And I mentioned that that is what we do in my facility. We start from the lab, positive results, we take the data, and then go back to the ward to find the patient with positive results because you want to identify the risk factors for infection. You want to confirm if it's truly HAI, and then you want to find other links. Are there other patients with such infections on the ward? So surveillance data that you're collecting, you may use various instruments depending on your facility, the forms you use, which I'll talk about later. But the important thing is that your surveillance data should ideally have all these parameters. Demographic data, so you have your patient ID, age, and gender. Admission details, dates of admission, dates of ward entry, because when was the patient admitted, will tell you whether the infection you're identifying now is HAI or community acquired. If you take the sample the day after on the day of admission that grew an organism, then this is not from the healthcare facility, so it's not HAI. Then infection details, dates of infection, the type of infection, is it after UTI, is it surgical site infection? The risk factors, does the patient have risk factors like having devices in place? Is the patient diabetic? Is the patient taking the antibiotics irregularly? So those are the things that you'll be looking out for. Presence of previous surgery. Then if you have laboratory data, did they identify any pathogen? What pathogen did they identify? And the susceptibility pattern to identify antimicrobial resistance. Then the outcome, is the patient recovered? Was it transferred to another unit or out of the facility? Or the patient succumbed to the infection or other morbidities? So what instruments you use varies. So some you can use standard forms for HI surveillance, which are readily available online, but many of them are for specific infections. So you have data collection forms for catheter UCI, data collection form for surgical site infections, and you can actually use all those forms in your facility. But you can have locally generated forms. We use locally generated form, and I'll show you a snapshot in the next slide. Then apart from having your instruments, your procedure is in manual, meaning that you have your forms and then you're filling them by hand, or you have electronic data capture, which you are using your electronic devices and then you're entering data directly on your devices, or you have a combination. So this is what we start with. Because we use a lab-based surveillance, the beginning of the form starts with the lab information. It's a manual form, so you can see handwritten information on it apart from the template. So it shows the date, the organism that was identified. And then after that, of course, I blurred out the patient details because it's a online presentation. But you can see yielded moderate growth of a particular organism. And then we go back to the ward to identify the patient and look for risk factors and signs of infection. And you can see at the end of it, the outcome here is that patients were admitted with the infection because that investigation showed that sample was collected on the day of admission. So this will be expunged from our HAI surveillance data, even though it's on the record, the manual record form, but it will not be on the information that we put on the surveillance data electronically. So you can see the electronic data entry now, which at the end of the day can show us the infection by ward, by units, and by particular infections. So you input based on this. And so at the end of the day, we can easily generate our analysis. So for data collection, that is what we do if you are doing a continuous monitoring. But I'll quickly talk about HAI PPS because it's an ongoing discussion about a more convenient way to have HAI surveillance information. So for HAI point prevalence survey, PPS is done for so many characteristics in the healthcare setting now because we may not be able to do a continuous survey, but you can do a point prevalence where your data is reflective of a single day of data collection. So it requires less resources than continuous surveillance, and it can easily estimate the HAI in that facility. And oftentimes also combined with antibiotic consumption. So you're doing both your HAI surveillance and antimicrobial consumption. So it helps with antimicrobial stewardship because they're looking for antibiotics and saying, oh, is it administered optimally? Are there indications or it's a misuse of antimicrobial agents? And then because many facilities are doing it at the same time, you can actually have a uniform protocol for benchmarking and policy development, particularly if it's done as a national activity. And then because you can do it frequently, so you can do maybe your PPS every 6 months, you can have easy way of assessing the impacts of interventions. If your PPS shows changing pattern or increasing or reducing, then you can monitor. So surveillance is not complete until results are disseminated to those who can use it to prevent and control infections. Because many times, many facilities collect data and just leave it there, whether on the table or on the system, without doing anything with it. That is not surveillance. You need to disseminate and provide recommendations for your surveillance to have been completed. And for you to disseminate or give a feedback, your data needs to be processed. So you analyze your data and disseminate the information. So what are we reporting when we analyze our data? You are doing HI rates. So if you only have your numerator, number of infections, then it doesn't say much, because if I say that there are 10 infections on the ward, it doesn't tell me much. But if I say there are 10 infections out of 12 patients who are at risk, that rings an alarm. But if I say there are 10 infections out of 3,000 patients, then you're relaxed. Oh, it's not so much. So you usually need, or you always need a denominator to assess that HAI rate. So HAI, you need to have your rate, numerator over denominator. And in the definition, remember I mentioned that it's not only healthcare infections, but related parameters. So for example, needle stick injuries can be an outcome that you want to assess. So surveillance can be outcome measure. How many infections do we have? It could be how many needle stick injuries are present in that on that ward. Surveillance could even be how well are people utilizing your sharps boxes, or how well are people disposing of refuse or healthcare waste in the appropriate color-coded bins. Then process measures, you can actually say, oh, how well are people complying to the hand hygiene recommendations, the 5 moments, are the people complying to it? So that's the process you want to assess. Are the people adhering to care bundles you want to assess? Are they adhering adequately to Katashida UCI care bundle, etc.? So I mentioned you have your numerator, which is the number of HIs or the outcome that you're talking about or you're investigating. And denominator is those who are at risk, not just everybody, but those who are at risk of that particular outcome or infection. For example, Katashida UTI, the numerator will be number of patients who have Katashida UTI, and the denominator will be all patients who are on catheter in that particular unit. So if it's the ward that you're looking at, then all those on the ward. If it's in the entire hospital, then all patients on catheter will be your denominator, and then the numerator will be all patients who have catheter-associated UTI. So your rate divide numerator by denominator, and you can have overall rate for your facility, number of HIs over number of patients that have been managed in your facility using the admission or discharge data, or specific rates. So infection rates by sites, surgical infection, wound infection, bloodstream infection, or by pathogen. How many medicine-resistant staph aureus do we have on this facility over how many patients have staph aureus infection? So you have to just define what your numerator is and what your denominator is. It may be how many staph aureus infection over the number of wound infections, because you want to find out how many wound infections have staph aureus. So you need to define what your numerator is and what your denominator is. So after you have calculated your rates, it's always nice to present it in a way that makes it clear for people to appreciate and understand. Particularly if you have multiple times of data collection, then you can present this in a chart. So to the right of the screen is a single measurement that shows you, oh, this particular HAI. You can see that the slice of the pie, the highest slice has a dark green. So ICU has the highest proportion of infections. So if you are trying to target your intervention, then you focus on ICU that has the highest rate of infection. Whereas if you're looking at a trend, that's if you have multiple times of data collection, is the one to the. So to the right is the pie. I don't remember what I actually said, but to the right is the pie, like a single measurement. And to the left is the chart that shows, or the graph that shows the change over time. So you can see the prevalence from 2.36 to 2.5 to 3.9, and then it drops. So you can easily see, okay, maybe during our intervention was in 2008. So there was an intervention, and then you see it drop. Then you can see our intervention was effective because there's a drop. Or if it keeps increasing despite intervention, then you know this intervention is not working. So you have to have a nice visualization that helps even those who are not core statistically inclined individuals to appreciate what you are presenting. So that's HIS surveillance. I'll go on to the challenges that we can encounter when we are collecting HIS surveillance data, or if we need to start. So these challenges hinder our ability to implement or sustain the program. So some start, they encounter the challenges and stop. And some are not even able to start because of all these challenges and the impact of the effectiveness of our IPC programs. So this is a run of all of them: funding, manpower, underreporting, inadequate testing, lack of standardization, technical capacity for analysis, timeliness of feedback, then the complexity of our surveillance systems. So for lack of funding, usually it's because there's lack of resources, particularly from the management to support IPC and HI surveillance. So of course, if you want to do HI surveillance and there's no resources, you don't have your data collection instruments, you don't have analysis, then funding may impact your ability to carry out surveillance. Manpower limitations, similar to lack of funding, you don't have staff that are dedicated to data collection, or they're not even trained. So they may be available, but they do not have the capacity to collect data. Laboratory capacity, if you want to have specific diagnosis and there's no laboratory equipment or consumables, or even if they are and there are no lab personnel, then it's difficult. Challenges of data collection is what is really seriously hampering many HLI surveillance because of inconsistent or incomplete data collection. You are able to collect this week, and next week there's no ability, or next month there's no data collection, or you have papers today, there's no paper tomorrow, no ink to print, or analysis, you collect the data, but you're not able to analyze, or there's nobody analyzing the data. Or even the reporting, if you get your infection in the lab and you go to the ward and the patient record does not have the information that you need, then you don't have the ability to actually collect good quality data. So that data quality can be impaired by various things. I mentioned about medical records not being complete earlier. Then if you don't have trained personnel to actually extract the data, so it's there, but you cannot extract it, or there's underreporting, mainly because you do not have those who are making a diagnosis, or they're not sending samples to the laboratory, as I mentioned earlier, then the data will be much less than the actual data. Like the chart I presented earlier, this graph showing UCH HI trends of 2.3 and 3.0, they are gross underestimates, mainly because we are relying on laboratory data and many patients do not get tested. So underreporting is a major problem. Erroneous conclusion can also be a problem because if you have your data analyzed and incorrectly interpreted, then you can have erroneous conclusions. Then start a wild goose chase of looking for what's not there because of wrong conclusion. Then lack of standardization, because many facilities have their own ways of carrying out data. So surveillance data in UCH may not be comparable with surveillance data in LUS or in Olabisi Obanjo University because we are not following the same protocol or standardization of data collection. What we define as UTI in my facility may be different from what even a facility within the same state calls UTI. So we cannot really compare data or interpret it in a way that the other facility would understand. Another major challenge is the timeliness of feedback. Many times data collection takes place, but we do not give feedback to those that can make use of that information. So it detects that there's an outbreak, but you do not, maybe because of lack of data collection or lack of opportunity of feedback, you do not tell them there's an outbreak, you do not give them recommendations. So everybody is wondering, so why are you collecting data? Because they cannot see the benefit. But imagine if you get the data, you provide a feedback, and not just a feedback, but tell them what to do to control that infection, and they actually do it, and they see, oh, these cases are reducing. Then the next time you talk about surveillance, everybody is interested because they see that your feedback and your recommendations are helping patient care and safety. So those challenges actually result in inaccurate data collection and analysis, incomplete reporting, difficult comparing, erroneous conclusions. So these are just the summary of what our challenges resulting on HI surveillance data collection. So now the last set of slides go to talking about recommendations for improving HI surveillance. And this is a summary of what I'll be talking about. So we need a strong leadership commitment, functional IPC program, involvement of stakeholders, comprehensive surveillance system, integration of HI, use of standard protocols, capacity building through training, data analysis, and leveraging technology for improved surveillance. So I see that my time is up, so I'll just quickly run through this. But the slides will be available. I'm sure it will be shared with everyone after the presentation. So institutional leadership is very important because once the leadership demonstrates commitment, then they give funding and allocate other resources like manpower, support training of healthcare personnel for IPC, because IPC is not something you just tell somebody, okay, you're in charge of IPC. They need to be properly trained. So when you have commitment, then they fund and train. Functional IPC program is very important because it's the backbone for all activities, including HAI surveillance. And because it's multidisciplinary, it's also an avenue for you to disseminate your findings. You have to go to all the worlds. You can just share your findings because the IPC program would involve every unit that is concerned with infection control. Human capacity, so you need to have adequate resources in terms of manpower and who are trained. Laboratory capacity, so you need to have good laboratory backing for IPC and HI surveillance. Then timely feedback, I've mentioned about what's the importance of having timely communication and feedback does. Technology helps us to really improve our surveillance. So instead of thinking about paper, printing, and no ink, we can use our mobile devices and a form we download online to collect our data. you can leverage on machine learning and AI to actually help you to extract the data and analyze it in a way that you understand, particularly if you have large data and you want it analyzed. You can also leverage on genomics if you have the facility. It helps you to actually track sources of infection to see, is it an outbreak or not an outbreak? And then if you integrate your HI surveillance with other data collection systems, many facilities use electronic medical records where you can integrate all your data collection, then it helps in improving HI surveillance. Also, if you have partnerships, you can leverage on collaborations that help to improve HI surveillance, particularly if they're available in a facility or at the national level. I'm sure they're doing that, leveraging on collaborations to strengthen IPC and HI surveillance. So this is the final slide. These are my resources, and I want to thank you for your attention.
Thank you. Thank you so much, Dr. Fumi. Thank you so much. Please let's appreciate her with her best emoji. It was a very beautiful presentation. You can say that again. I know that we do not have much time, but I will quickly take questions and contributions, comments. We're open to that now. I don't know if anybody have questions. It was a very detailed and interesting section. Thankfully, the slides will be shared with everyone. Do we have questions? When she was talking about the challenges, it was also very interesting to see that she mentioned how we can close up the gap, the loop, when she was giving the recommendations. So do we have questions from the floor? Let me check now. Okay, yes, I can see a hand. Go ahead, Dr. Safia. You have the floor now, your question. Unmute yourself, Ma, so that we can hear you. Dr. Safia, you have the floor. Unmute yourself, please.
Yes, good afternoon, everyone.
Good afternoon.
Good afternoon, Dr. Makunjomo. Thank you very much for that.
Good afternoon, yes, ma'am. Thank you very much.
Insightful lecture, although I missed part of it. But the ones I met, I really appreciate it. I learned a lot from it. My question is, in my own facility, I am the IPC focal person for a Solo General Hospital. I still got a message from our consultant surgeon yesterday that he's been having a lot of wound breakdown from his surgeries. So I've discussed with him that we are going to have hospital-acquired infection surveillance on surgical wound infections. So how do you advise that we go about it? What samples are we going to be collecting? Who is going to be in charge of the data? I just need some guidance and some direction on how to go about it. Thank you.
Okay, thank you very much. Do you have an IPC program or team in place?
That's good.
So you mentioned that you are the IPC focal person. Did you say focal person? Hello, ma'am. Am I audible?
You're audible, but
okay, I was asking. We need to have some background to be able to respond to that question. So I asked if.
Please, I can't hear you.
Yes. Do you have an IPC team or IPC program? Or you are the only one involved in IPC in your facility? Okay, I don't think she can hear me, but let me just say that if you have an IPC team, then it's a function of your IPC team to, what he's talked about looks like an outbreak already. So you don't need to wait for the official flag off of a HI surveillance program. You need to investigate that one while you are going ahead with your surveillance activity. So what you need to do is to investigate. It won't break down, then the surgical procedures, are the instruments sterile? So you need to test sterility of the instrument being used. What about the dressing materials? Are they properly sterilized? Because I'm considering that it's probably an infection during surgery or post-surgical wound dressing. So you can ascertain that your instruments are sterile, your dressing is sterile, Then you go on to what about wound care? How are they dressing it? Or the patients, are they touching the wounds when, because sometimes he goes to the ward, a patient doesn't think people are looking and he opens the dressing and touches it, gets it infected. So what you need to do is to fully investigate, but you don't go about it in a hazard manner. That's why I asked if you have an IPC team, they need to fully discuss outbreak investigation and management, which even is related to surveillance, is different. So what you are doing in that case is outbreak investigation and management, not this actual surveillance that's you're not yet seen any problem, but you're looking out for it in case it comes up.
All right. Thank you so much, Ma, for the response. Dr. Safia, I want to believe that you heard her clearly. Okay, she's muted. Okay, thank you, Ma, for the response. I hope that she's able to take it up from there.
Glad to get across. Maybe we can discuss after the program because I don't think our network is very good. So we can discuss after. Yes.
Oh, that would be great. Thank you so much, Ma, for that. Okay, so Dr. Abiodun, please go ahead. You have the floor.
Okay. Good afternoon, everyone. I hope I can be heard.
Yes, very clearly.
Okay. Thank you so much, Dr. Makojola, for such a beautiful presentation.
Please call me Prof.
I will still call you Prof now. You know that's what I always do. Thank you so much, Prof. It was really enlightening. And HAI surveillance is something I'm particularly passionate about. About 2 years into the program, when you mentioned HAI surveillance, I just distanced myself away from it. And I think that's the attitude that most IPC practitioners have when it comes to implementing IPC in the country. But we say it's a core component of IPC, core component 4. And we say that you have to implement all core components to get a robust IPC program. So over time, I have realized that if we say we're implementing IPC, and we do not start to make efforts to include surveillance as part of what we do, it will be like being on a journey without a destination. We encourage people to adhere to the proper IPC practices, to wash their hands properly, to discard waste properly, injection safety, all these things. But if we cannot put a measure in terms of the impact of what we're doing, people would tend to get disappointed and discouraged over some time. So at some point, we need to start thinking about incorporating surveillance in whatever manner, whether it's point prevalence survey or an ongoing thing, or even the lab-based surveillance like you suggested. But we cannot continue to see that IPC is only about ensuring that we wash our hands or keep our environment clean. And because of this perspective I have, we try to have a point prevalence survey across some of our states. I work with some partners, some CDC partners, and I think we were able to work in 4 states. And the picture I saw made me know that HAI surveillance, is very, very critical to improve the quality of care that we provide. If you look at what Prof talked about, the questions that we'll be asking when we're doing this survey is questioning the quality of care that we provide. We are going to be talking about diagnostic stewardship, then antimicrobial stewardship. How do we make our diagnosis in our facilities? Is it by syndromic management that we make our prescriptions? Our prescription patterns too will also be looked at. You understand? So when we are doing our surveys, all these things will be asked. How do we collect samples that are tested in the labs? Do the labs have the capacity to actually, do culture? If we are going to make diagnosis of a HAI without culture most of the time, you know that you cannot make a diagnosis without a culture result. Now, the question I will ask next is that how many of our facility actually do blood culture or stool culture or urine MCS? If we are not doing these things as a standard, it will be difficult to adequately estimate how much healthcare associated infections we're dealing with. The country, based on the meta-analysis that was recently done by CDC with a partner, they say our HAI prevalence is about 15%. But we go to some facilities that we will now see like 2% HAI prevalence, which is not true. And it's simply because the parameters to make the diagnosis are not in place. For example, now we went to a facility where a child was placed on meropenem for about 3 weeks. And a dose of meropenem over maybe 24 hours is almost 30,000 naira. And we asked that was a blood culture done for this child before placing this child on meropenem. They said no. That same facility, for every client that we have, ceftriaxone is prescribed. For every case, ceftriaxone, in fact, I think for stroke in particular, ceftriaxone was prescribed. What is the basis? So what I'm trying to say is that when we incorporate HAI surveillance in our practice as IPC professionals, it improves the quality of our IPC program. Remember, the whole aim of IPC is to reduce HAI and antimicrobial resistance. So if we say we're implementing, to know that we're making a difference, we must start to see that, we gradually start to incorporate surveillance into our activity. It's going to be an incremental thing. If your IPC program is not strong, don't even bother. If your lab does not do culture, don't even bother. If prescription patterns are not followed up in your facility, don't even bother. If documentation is a gap in your facility, do not even bother. So we need to put all these things in place. Then we can now start putting in surveillance, whether by point prevalence survey or a lab-based surveillance structure. Now, it's not as easy in terms of challenges, which she eloquently, mentioned. But another thing that I notice is poor documentation. You place a client on antibiotics, you leave it open. You understand? You leave it open, and even when you prescribe, you don't use the right medication. Then also another reason why
Dr. Abiodun, you have muted yourself. Huh?
Yeah, Dr. Abiodun, please unmute. I was trying to mute that other person.
Okay, sorry. Where did I drop off?
So just 1 or 2 seconds.
Okay, that's fine. So another problem, not to exonerate the doctors, is the patient cannot afford the cost of some of these culture tests. And even if they do, how long does it take the labs to come up with the results? Sometimes these patients are already, discharged before the results of this culture comes back. So the doctors are even discouraged. Another gap between the doctors and the lab is that disconnect, that synergy is not there. Sometimes these cultural results are ready and is documented in the lab system, but this is not communicated back to the doctors. So these are things that we must look at as practitioners to see that we strengthen. Dr. Sophia mentioned that there seems to be a challenge with a wound breakdown in her facility and was asking of how best to go about it. Now, there is a way that the WHO has structured IPC, and the truth is that in this country, the way things are, until we start to contextualize IPC with our own challenges, we'll always have issues. So besides having an IPC team, what we have done in most of our facilities is that within those teams, you have subcommittees. In fact, if you are an IPC team member and you do not have a rule clear cut for you, you are not supposed to be on that team. So we have subcommittee. There's a committee that will be for surveillance, HAI surveillance. Even if you are not started, have a team that will be looking out for surveillance. Now we're having Lassa fever outbreak. What are you doing as an IPC team to see that you are monitoring the trend? Are you doing contact tracing within the healthcare facilities for those who have come in contact with that Lassa fever patient? You should have also a healthcare worker safety committee, subcommittee. You should have a subcommittee for ward rounds. How would you pick out, gaps in the system if you do not have ward rounds on a weekly basis? So until we start to strengthen our IPC programs within the facilities, we will find it difficult to start to implement HAI. There's so much more that we can discuss here, but I know that time is fast spent, so I wouldn't go so much into it. So let's strengthen our IPC programs, then we'll now start to layer, HAI surveillance. Then AMS structures too need to be strengthened. You need to have an antimicrobial stewardship program in your facilities before you start a HAI assessment or HAI program in your facility. An antimicrobial stewardship program is very, very critical. If you're able to have that, the gaps you'll find will be far less, meaning that you have a team that is looking at prescription patterns. You have a team who is looking at the lab. What kind of results are we getting? Is there follow-up? You understand? So these things I think are very critical if we want to start doing healthcare-associated infection surveillance. Thank you very much.
Thank you very much, Dr. Isa. I agree with you, except that to say that we may not have everything very ideal before we start. Sometimes it's even your surveillance, ad hoc surveillance activity that stirs up interest in IPC in your facility. So if all you can do is maybe try to identify infection in a particular ward, get some management to know about it. Sometimes that's all the management needs to say, okay, we could invest in IPC activities, and then they start to support from there. Thank you. Just to add to that.
Okay. Thank you so much. Thank you so much, Dr. Abiodun, for that elaborate contribution. I hope that everyone is taking notes, especially to be able to replicate it in our facilities, the need to, strengthen IPC in our respective facilities, and also be able to translate data to, reasonable actions respectively. So I don't know if we have more questions, contributions, comments from every one of us. Anybody? Let me see. I've gone through the chat. I've not seen any question. So do anybody have any more comments to add, contribution or question? We're looking forward to another section next 2 weeks. Thank you so much, Dr. Fumi. It was quite a detailed and interesting section, and also offering to share your slides with us so that we can go back and then, look into them again. It's something that we really, really appreciate. Thankfully, also the session is being recorded and it will be shared with everybody by Dr. Abiodun. We're going to be having another section in 2 weeks' time. Dr. Lagoke will be taking the section on linen and laundry management, and that's it's going to be about our last section. It's really been a very productive time with everyone in the last couple of months. I also look forward to having us in 2 weeks' time. Like I said, Dr. Logaku will be on the section that day, and the links will be shared with everyone. So thank you to everyone that has joined today. It was quite a very beautiful time here with Dr. Olufumilola. Thank you so much, ma. We really, really appreciate. I am aware that you have a very busy schedule currently, having the trainings that are ongoing, and I appreciate that you're able to spare us this 1 hour for this great section. Thank you so, so much. We do appreciate. And every other time that I reach out to you, ma, please, I hope to have you again. Thank you. So thank you
You're welcome.
everyone for being part
Yeah.
of it. Thank you, man. So thank you everyone. Like I
Thank
said,
you, everyone. Thank you for
yeah.
the kind comments. Thank you very much. Bye.
Okay.
Thank
Thank
you.
you. Thank you.
All
Bye-bye.
right. Goodbye, everyone.